Hi, my name is Ravish Sachar. I'm the Chief of Heart and Vascular Services at UNC Rex Healthcare in Raleigh, North Carolina. And I was the principal investigator for the US, along with a global principal investigator, Tomas Zeller, for the Ranger DCB trial, comparing the Ranger drug-coated balloon versus plain angioplasty. So the device investigated in this trial was a Ranger DCB. The Ranger DCB is a drug-coated balloon coated with paclitaxel. It is coated at 2 micrograms per millimeters squared. And this device was compared to balloon angioplasty alone. The test device, the Ranger, as I mentioned, contains paclitaxel along with a excipient called the Transpax excipient, which is proprietary, and is mounted on an 018 Sterling balloon platform. And that is a device that was tested against balloon angioplasty in the Ranger trial. So this study was a randomized controlled trial, multi-center prospective trial. It was a 3-to-1 randomized design with 3 patients enrolled in the Ranger arm for every 1 patient enrolled in the PTA arm. It was single blind in design, and it was superiority to designed for effectiveness, designed to show superiority of the DCB as compared to the plain balloon. This trial had 3 components. One was the main randomized trial comparing the Ranger DCB to plain angioplasty alone. There were 376 patients enrolled in that study. In that, there were 278 patients who were enrolled in the DCB arm and 98 patients who were enrolled in the angioplasty arm. In addition to the main trial, there was also a pharmacokinetic substudy and also a long balloon substudy. The results of all 3 of these components at 1 year have already been presented. And what we have now are 2-year data on the Ranger 2 study. So what we found is that the benefit seen of the DCB in terms of superiority in patency, in terms of freedom from events, that was seen at 1 year was maintained out to 2 years as well. So what we found was that at 2 years now, as compared to what we found initially at 1 year, there was a continued improvement in patency as compared to balloon angioplasty alone. At the end of the follow-up period, at 760 days, in a Kaplan-Meier analysis, the primary patency was 79.1% for the Ranger balloon and 67.8% for the plain balloon. When you look at it in terms of freedom from TLR, which is most important for patients, there are 87.4% of patients who received the drug-coated balloon had no further interventions required at 2 years, as compared to 79.5% of patients who received the standard balloon who did not require any further interventions at 2 years. And both of these, both the primary patency and the freedom from TLR, were statistically significant differences. In addition to that, if you look at the sub-studies now at 2 years of patients who are traditionally considered high risk, so patients at high risk would be women as compared to men, patients with chronic total occlusions at the beginning of the procedure, or patients with severe calcification. When you look at those 3 subsets, there were important findings there as well. So starting first with the chronic total occlusion subset, of which there were 80 patients in the trial, there was a difference in primary patency at the end of the follow-up period at 760 days of favoring the drug-coated balloon as compared to the angioplasty, plain angioplasty alone, with 69.4% patency at 760 days for the Ranger DCB arm versus 54.5% patency for the plain balloon arm. And similarly, there was a big difference in freedom from TLR as well among patients with chronic total occlusions at the beginning of the study, with 85.6% of patients with CTOs at the beginning of the study, with no further interventions required at 2 years versus 62.8% of patients in the plain balloon arm requiring no further interventions at 2 years. So a larger delta among these patients with chronic total occlusions. Similarly, among patients with severe calcification, traditionally a high-risk cohort, 194 patients in total with severe calcification defined as PACS grade 3 or 4. Primary patency at the end of the follow-up period at 760 days at 2 years was 84.3% for the Ranger arm versus 66.7% for the plain balloon arm, and similarly, a difference in freedom from TLR favoring the DCB arm at 90.9% versus 79.6% for the DCB arm versus the PT arm, respectively, again, significant differences in both arms. This is very significant in that close to 91% of patients with severe calcification had no further interventions required when treated with the Ranger DCB out to 2 years. And then finally, when you look at women versus men, there were 105 women enrolled in the study versus 173 men enrolled in the study. Traditionally, women have had worse outcomes as compared to men, maybe smaller vessels being the reason. But in this particular study, there was no significant difference found between men and women in terms of outcomes at 2 years. So overall, what I would say is that we have now at 2 years a continuation of the benefit that was seen at 1 year in terms of our overall patency, in terms of freedom from TLR. But also, if you look at high-risk subsets, the benefits are favorable as well. Patients with chronic total occlusions at the beginning of the procedure did better, and the delta and the difference as compared to plain balloons was more. Patients with severe calcifications did better as compared to plain balloon when treated with drug-coated balloons, and the difference was larger as compared to the overall cohort. And women and men, the results was exactly the same. And the final thing I would add is that at 2 years, there's no difference in mortality between the two groups. This has been something that's been followed closely. We don't have 5-year data for this yet, but at least at 2 years, we now know that there's no difference in mortality between the drug-coated balloon arm versus the plain balloon arm. So we now know that patients with femoral popliteal disease who are treated with drug-coated balloons, overall, we know that those patients do better than angioplasty alone. That has been well established. We also know that this is not a class effect and that the benefit seen of the drug varies between the platform that is used. The benefit of the Ranger DCB at 1 year as compared to angioplasty alone was pronounced. We now know at 2 years, it's pronounced as well. Those patients who are at high risk do especially better with drug-coated balloon versus plain balloon, and we know that it's safe. So for patients who have significant femoral popliteal occlusive disease, treatment with the Ranger DCB can be done safely with the expectation that there will be an effective response among patients overall, but also among patients at high risk for restenosis, such as CTOs, such as patients with severe calcification, and equivalent results between men and women. So the key take-home messages from this trial is that for physicians who are treating their patients with occlusive femoral popliteal disease, they can be confident that when they treat their patients with the Ranger DCB, even among those patients with high-risk features such as severe calcification or CTOs, or among women, that they can expect to have good results in terms of patency and freedom from TLR with good safety out to 2 years. And this 2-year data gives them the confidence that they can do this safely for their patients.